So now, everybody, I'm going to turn to the one and only Beth Allen. You see, I told you she got a nice top on, didn't I? Right at the beginning.
Thank you, John.
Fantastic. So Beth is digital nurse at the Christie NHS Foundation, and she's going to talk to us about enabling better communication with technology to improve cancer care. Beth, we are all ears and all eyes on this. Thank you very much, and we'll then have a little a short Q&A at the end of this. But over to you. Thank you.
Thanks, John, and yeah, thank you for having me. So yeah, as John said, I'm a digital nurse at the Christie, which is a specialist cancer hospital in South Manchester, and here to talk to you about enabling better communication with technology to improve cancer care. So I suppose a little bit about me and why this is important to me. So I've worked at the Christie. Well, I've really been there since 2016. I was a student nurse at the Christie. I was then a healthcare assistant at the Christie in my final year of nursing study. When I registered in October 2018, I then did the rotation programme. So I spent 6 months on a head and neck ward, 6 months on our critical care unit, and 6 months on our outpatient chemotherapy and immunotherapy unit. I then spent the 2 years of, well, the main 2 years of COVID on a very busy medical inpatient ward. So looking after patients at all stages of their cancer care. So either giving inpatient chemotherapy or immunotherapy, looking after patients who were poorly enough with their side effects of their treatment to be admitted, or sadly looking after patients at the end of their life as well. So that was a really busy 2 years. And then in April 2022, I became a digital nurse, which a lot of people immediately say, what on earth is that? Essentially, I'm the link between the clinical teams and the digital teams. So a lot of my job is advocating for clinical staff to make sure that any technology that we introduce is fit for purpose, is actually going to save us time or money, or improve safety or experience for our patients. And also, I feel like I'm the translator between the two teams, because clinical people and digital people both speak their own language, and everyone uses different acronyms, and I'm still trying to work out which is which and what means what. But basically, why this topic is important to me is because at all stages of, everywhere I've worked and all stages of my career, I've come across patients with communication barriers that has probably meant that they've had sort of less equitable care than other patients. You know, when I worked on the head and neck ward, the patients who have had radiation treatment to that area or have tumours obstructing that area, they would struggle to speak. They would get really severe mucositis, so it could be really hard to understand those. Different language barriers. I had an Eritrean patient on critical care, and Eritrean interpreters are really hard to get hold of. So that was a sort of modelling along of language line, Google Translate, and relying on the patient's friends. When I worked on the outpatient chemotherapy unit, I had a deaf patient that I'd quite often treat, and he was really good at lip reading, but sometimes he'd be writing things down on paper. So, and I know that those, you know, and that's just a few examples, and I know that those communication barriers aren't unique to me, aren't unique to my hospital. They're experienced across the NHS and probably worldwide as well. So it's definitely important to me that we can communicate better with our patients, because those barriers are there, and I think everyone deserves equitable care. So introducing CardMedic. So just after I started as a digital nurse, the Trust purchased CardMedic. It's a communication tool. It can be downloaded as an app or accessed on a web browser. You can do it for free. You can download it now. You'll get a small selection of the library of scripts. When the Trust paid for them, obviously they got access to the full library of scripts. There's just a few there on that screenshot. So they're listed alphabetically, and they cover a huge range of topics. And then there's lots of different functionality within that. So in the screenshot on the bottom left, you can see the allergy script. It's nice, easy language. It's how you would speak to a patient. There's not too much medical jargon. Going across some of the functionality there, you can break down the script line by line, or you can play the whole script. The two little hand symbol, that indicates British Sign Language. So there's actually videos on some of the scripts as well for our deaf patients. There's easy read, so all of the scripts are set to a reading age of 8, but if you select easy read, it will drop the reading age to 6 for patients that might need that to be more comprehensible for them. You can email the script to the patient, so if they would prefer to have it on their own device or read the information a bit later on, you can do that. You can read the script aloud, either in English or in the language that you've chosen. That little question mark icon that you can see, that takes you to the any questions script. So if you've given a lot of information, you can link to that script, and you can check the patient's understanding. You can bookmark the script, so the ones that you're using the most. The little palette icon at the top, that the paint palette icon, that enables you to change the background color of the script. So you can change it to a yellow, a green, or a black background. So if patients are dyslexic, they might be able to read that more easily. And then the feature I use the most is the little globe icon that takes you to choose one of the 44 different languages that CardMedic has available to be able to translate those scripts. I've not done a screenshot there, but there's also a really nice little introduce me page. So there's your name and your job title, and you can put a picture and explain sort of who you are and why you're using CardMedic. And then there's also live translate. So that works a bit like Google Translate, but you can record what the patient's saying and it'll come across your screen in English, or obviously vice versa. You can go a bit off script as well if needed, because the scripts don't always fit exactly what you want to say. So that's a little bit about CardMedic. Obviously, I don't work for them. There's probably much more information that they can give in a proper sales pitch, but that's just to kind of explain the platform and some of its functionality. So I suppose going back, we purchased it and I could see the benefits of the platform, and I was talking to staff and patients about it and getting a bit of a buzz. But obviously we're an oncology hospital, and we were the first oncology hospital to purchase CardMedic in the UK. And so I was really keen to kind of maximise that potential and make sure that we had scripts which were appropriate for our patients and for the care that we're giving. So I started to write some oncology scripts because CardMedic are always really keen to evolve and adapt and grow their library of scripts and add to the languages as well. So I started to write the oncology scripts alongside our specialist SACT nurses. And then once we'd sort of decided on the bare bones of the script, I sent it to UCONS for approval. And I was really keen to do that. And I always like to mention that because UCONS are the UK Oncology Nursing Society. And when I first got trained on giving chemotherapy, it was those competencies that I had to pass. And they kind of set out what you need to say to a patient in terms of the first time they have chemotherapy and as you're assessing them throughout treatment. So I was really keen to make sure that not only they were happy with what I was saying on those scripts, but also that it was generic enough to be used across the UK. I didn't want to be using any language that was too sort of Christie specific, because obviously the hope is that the scripts will get used, well, not only in the UK, but CardMedic is getting used worldwide as well. So I needed it to be generic enough to be applicable to all patients receiving chemotherapy or immunotherapy. So then once the script went through some stylistic changes, just to make sure that the language I was using was kind of fitting with all of the terminology used in CardMedic, it was uploaded to the app, and it's now available for staff to use to communicate with patients. I'm waiting at the moment. CardMedic are in the process of developing a dashboard so we can kind of get more of the data on that to see which of the scripts are more popular or which staff are using the scripts the most. But anecdotally, I've spoken to staff and they've luckily said that they found the scripts useful. I know that one of the nurses on our outpatient SACT unit treats the same patient every time she comes in for her chemotherapy, and this patient doesn't speak English, and she says that she's used the CardMedic script and she has then been able to assess the patient and give the patient all the right information pre-treatment. But I didn't stop at the SACT scripts. I wrote a few more. One's for acidic drain, because there was a chest drain one and not an acidic drain, and a lot of our cancer patients suffer with ascites. The identity check script is just the usual name, date of birth, first line of address, because obviously I wanted to make sure that we were safely giving chemotherapy. And then the CVC line script as well, just because the scripts were initially created in ICU. So the central lines they refer to were often the ones in the neck, in the jugular, but in the Christie we use a lot of PICs and ports and HICs in the arm and chest. So I just wanted to make sure that the scripts were adapted for that. And even just a little script to say, can I access your line? Because when patients are wearing clothes or high neck clothes, it's really difficult when you're trying to act out and speak to someone and say, can I access your line? But if you can just get the script to say it, then they'll present you with the line, and there's less fumbling around and less of a silly game of charades. So that's things like that are just helpful, and those were the sorts of things that I wanted to make sure that we included. I wanted to kind of be thoughtful in the way that we wrote the scripts as well. We're in the process at the moment of just going through the stylistic changes for the radiotherapy and the proton beam therapy scripts as well, because I am no expert in those areas at all, but luckily we've got subject matter experts across the hospital who are, so they've kindly written the script. So I think hopefully at that point then we will have covered sort of the main aspects of cancer treatment that we give at the Christie, and hopefully that will help not only our patients but anyone else who decides to download CardMedic. So I think I'm really grateful for the support that I've had from CardMedic in writing the scripts. It's been a really collaborative process. I think the brains behind CardMedic are brilliant. Rachel, the anaesthetist who dreamt it up, she was writing things down on paper in critical care during COVID because she couldn't communicate. And then that became the digital platform, and then it's absolutely snowballed into this platform that can hopefully enable more equitable care for patients, and particularly cancer patients, because I just felt like when I was on the ward, if you had a patient that didn't speak English in your bay and the other 3 that did, or the other 4 that did, I didn't feel like I was informing those patients about their care as much as the other 3, or I didn't feel that I could understand their needs and they could articulate their needs as easily. But with an app like CardMedic in your pocket, hopefully you've just got that additional tool as a bit of a backup to help you communicate with those patients, because things like language line and obviously things like Google Translate don't always work, and don't always work for medical conversations, whereas CardMedic is designed for those medical conversations. And particularly for myself as a nurse, I felt that when I was doing those 12-hour shifts and the interpreter would be booked, which is great, but for the 1 hour that the doctor was there doing their round, and they obviously had to have very important conversations with the patient, but then I was left with someone for the other 11 hours of my day who maybe spoke very minimal English, and I probably don't have the best Polish or Punjabi or something. So it would have been much more useful if I had had CardMedic for when I was working clinically, but hopefully by implementing it and sort of championing it around the trust, it's there for other staff to use as well. As I say, just to make sure that our patients feel informed and safe and are receiving equitable care. And I think particularly for our cancer patients as well, because it must be so scary to have a cancer diagnosis. And then it's also terrifying being in hospital. And then you don't understand anything that any of the doctors are saying to you, or you have limited understanding of all of the information that's getting thrown at you. It must be scary enough being, for example, English in an English hospital, but if you can't understand some of the information either, then I think it just adds to how overwhelming it must be. So I'm really keen just to keep promoting CardMedic and keep writing scripts and developing scripts for the oncology section and for any of the other sections that are relevant, so that we can try and use this app to communicate better with our patients and support them through their cancer care. And I suppose just a thank you to CardMedic for always putting the patient at the centre, and for designing an app that is so patient-centric and champions being supportive and collaborative with the trust that they work with as well. I think I whizzed through that far too quick, but that's all I had to say. Thank you, and if you've got any questions, let me know, and I've just put my email address there and my Twitter handle as well.
Well, first of all, congratulations, Bethany. I think that was fantastic. I know that you're clearly a convert to CardMedic and you're an absolute advocate for them, but there's no mistaking the authenticity of your personal experience. And I think that's the bit that I particularly warm to. When people tell it how it really is, then I think that's all the more powerful. And you did a great job in that regard. Any questions for Beth, I wonder, from anybody, please? They'll come along in a minute, Beth. They're just digesting what you just said. Can I just ask, are you aware of any other resources of this type? And I know CardMedic is your preferred one. Are you aware of any others? The obvious question is, well, why isn't everybody using this? It's clearly played a huge part in what you do. It clearly plays a huge part in the experience that the patients receive when they're in the Christie. You just think, gosh, we are such a multicultural, diverse population these days, deliberately so and laudably so. But, kind of part of the obligation that we therefore have as a society is to make our access to services seamless and easy for anybody, no matter their language or background. I just wonder. It just seems like one of those things. It's kind of everywhere should have it, shouldn't they?
Yeah, I suppose some of it is cost. Obviously, there is a free version of CardMedic, but the scripts are limited.
Do you know how much it is? Anybody know how much it is?
I can tell you how much we paid for it, but it's about 1/10 what we paid for CardMedic is 1/10 of what we pay on interpreters every year. And I'm not saying it replaces interpreters.
Yeah, we don't want to do the interpreters out of a job. They are great people.
Because obviously it wouldn't stand up for gaining written consent. You know, there's obviously, particularly in cancer care, we've got to break bad news or have complicated conversations. That's where the interpreter's job lies. But it's those, what I always say, like the bedside conversations,
it's for everyday interactions. I get that.
You know, what would you like for tea? Those kind of things. I think that's where it really comes in handy.
All right. Well, let's not break any commercial confidence, because I certainly don't want to get you into trouble, Beth. If anybody's interested, they can probably go and find out for themselves by contacting the company directly. All right. Richard Wyatt Haynes has got his hand up. Richard, what would you like to ask?
And Beth, thank you so much. In a way, I'm going to pick up on something that John just alluded to, that built on what you said, which is this feels like a no-brainer. All right. I think that you didn't use those words, John, and you asked the question, why isn't this picked up and taken everywhere else? Right. And I think, Beth, this echoes a challenge that people that sat in my seat every day feel in terms of what we've developed. Doesn't matter what I'm doing, but us in the sort of digital health world, producing, innovating, bringing new ideas to the table that make a massive difference. Then you see it happening, but it's so hard to get picked up and adopted across the system, and it's so painful. And I think one of the things John just reminded me of is, we've talked about this before, John, the lack of vision of really what a digitally enabled health system looks like in 2030, 2025, 2030, that actually paints a meaningful, real picture that people are behind and are making happen, rather than what's going on at the moment is a whole series of little projects such as yours. I'm not belittling it.
No, yeah.
And mine, little projects in little places in sporadic ad hoc ways without any real coherence. And if I walk onto a ward, and maybe not yours, Beth, because of what you're doing, but the ward next door, and ask, what does it look like? If I asked a healthcare assistant, if I asked a nurse, if I asked a doctor what digital health looks like in their hospital in 2025, 2030, what shape would that take? What would it look like? What would it feel like as a patient, as a healthcare professional? If I got an answer, I'd be lucky. If I got an answer that was coherent, and if I got one that was shared, I'd be blown out the water, and it doesn't exist. So therefore, in the absence of that clarity, of aspiration, of hope, of possibility, your project, which is just wonderful, sits in isolation, sits on its own, and will get picked up here, there, and everywhere. And what a waste. But that's the sad world I live in.
Well, maybe, Richard, you've just come upon the perfect project for this group. The perfect project for this group is, what does digital health and care look like in 2030? We could do that. We could do that as a project. That would be a really interesting report. I'm going to let Beth just comment upon your observation there.
No, yeah, I was just going to say, I think it's awareness, you know. So Rachel and Tim are the co-founders of CardMedic. Obviously, I'm just a customer of theirs. And I think that they are doing their absolute utmost to raise awareness of this app. But I completely agree that it's the bigger shape of digital, you know, digital health is bigger than just this app, isn't it? Obviously. And I agree that even in, you know, my hospital, my role being a digital nurse is a fairly new role. We're a small but growing team in quite a small hospital. But I agree, you go onto the ward and you ask anyone about digital health, and, you know, people don't realise the scale of it, and that it's growing at pace, and that it is actually important to them, and it should be important to them, and it should be important to their patient care. I think people just think, oh, it's just the computer, or it's just, and it's, but you see what I mean, don't you? But obviously that's a bigger conversation than just CardMedic, isn't it? It's huge.
But it's how we get out of this hole in truth, that we're in. And John's oppo this morning, Roy was writing about shoes and getting out there on the ward and talking. And I wonder how often executives around the country and leaders around the country are out there explaining, engaging their teams in understanding really what we're working towards to make this possible.
The good news is that CardMedic are pitching at our Dragon's Den event on the 18th of May, Tarantara. So we're doing our best for them, Beth, and I think you've been a brilliant advocate today. But Sonia's got her hand up. Sonia, would you go next, please?
Lovely to meet you, Beth, and what an amazing story and an amazing product. I was kind of interested because I've never met a digital nurse implementer before. And it seems to me that fundamentally or crucial to the success of it in your clinical setting was your contribution, you know, what your real need was and what the needs of your patients were. And you were able to, you know, really enhance the scripts for that clinical context. Are there many of you in the UK? We don't have any in Ireland. So is this a relatively new, you know, qualification? And fundamentally, is that, sorry, I keep using fundamentally today, it seems to be my favorite word. Is that crucial to the success of tools like this in clinical settings, that there would be someone like you to really make it appropriate for the context?
So yeah, obviously I tried to give a few sentences to explain what my role is at the beginning, because a lot of people, even in my own hospital, don't know what a digital nurse is. They assume that I'm tech support. So sometimes I walk on the ward and people say, my Wi-Fi is not working. And I was like, well, I did the same nursing degree that you did. I can't fix the Wi-Fi, but I know the guy that can. So a lot of people think I'm tech support, even in my own hospital. I'm the third digital nurse at my hospital, so it's fairly new. We're a small team of 3 at the moment, but growing. There are other digital nurses in the UK. There's councils, there's networks, there's groups. So I sit on a national council of digital nurses and midwives. I've also set up a regional council in the Northwest for digital champions, digital clinicians, so digital AHPs, anyone who's interested in digital. So we have a Northwest Regional Council that kind of feeds into the National Council. So I think most trusts in the UK are trying to, well, a lot of trusts now are meant to be having, a CNIO or a CCIO, so a Chief Nursing Information Officer or a Chief Clinical Information Officer. I've got one at my hospital to try and sort of be the leader of that digital team and filter it down. So I think it depends on the size of your trust and depends on sort of your digital maturity of your trust, on how big your digital team is. But yeah, I think that having clinical experience is quite crucial. I think that I don't think I would have been able to do this job if I hadn't spent a few years on the ward. I've only been qualified as a nurse for about 4.5 years. I'm not trying to say I've got loads and loads of experience, but those 3.5 years of clinical experience that I did have really helped to guide me in the last year in this digital nurse role. And as I said, sort of advocate for the patients and as you say, know what the patient's needs, know what the staff needs are, to help sort of guide that digital transformation. I hope that's answered your question. Sorry.
Yeah, thank you. Great.
Perfectly. Thank you very much, Beth. I don't think anybody. Oh, hang on, Mary. Mary's on. She says, how far is the information given to the patient via scripts or otherwise incorporated into the patient record?
So at the moment, it isn't integrated into the patient record. We at the Christie stupidly have an in-house built EPR. It does have its perks, but equally it makes it very difficult for things to integrate because we aren't, we don't have a big supplier helping us. So it's not integrated into the EPR at the moment, but that's definitely something for me to consider. Actually, that's a good point.
Well done, Mary. Absolutely on the money once again. Thank you very much indeed. Would anybody else like to ask a final question before we move along? Okay, well, Beth, thank you very much indeed. Well, again, really uplifting. I feel good about that. I feel good about hearing success stories and so on. And clearly, Beth is, I know you say you've only been qualified for 4.5 years, but my goodness me, if all the nursing team in the NHS look and sound like you, it would be a better place, that's for sure. There we are. I love your enthusiasm. Thank you. I think this idea of a future of digital tech and care looking at 2030 would be quite an interesting project for this team to set its mind upon, even to the extent that maybe one of our forthcoming meetings, we actually do it as a roundtable collaborative, and we each go away and think of our own kind of vision for what the future might look like. I think that might be an interesting project, and then we kind of draw all the different views together and try to paint a sort of a virtual landscape that says this is how we think it could look, and then we can have another one which says this is how we think it will look. And how do we get the ground between could and will kind of smoothed? I think that's the phrase. There we are. So there we are. Shane Tickell says he thinks this idea is rather good. So should we do it? What do we think? Just put your hand up if you think it's a good idea. Should we do it? Put your hand up if you think it's a dreadful idea and you want nothing to do with it. And put your hand up if you think, do you know what? This is already going on too long. I really fancy a cup of soup. Oh, okay. Well, I think we should do it in that case. I think overall that seems to be it. So yeah, we're going to give that a go. Is that all right with everybody? I will be seeking your views. Jade Maloney, the one and only, the queen of virtual conferencing, will be going out, and we'll do a little note out to you, inviting you to provide your ideas, and we'll create a facility for doing that properly. So there we go. Mary says she supports it. That's good. Excellent. All right, that's it for today then. In that case, once again, huge thanks to Beth and to Sonia. Can I just draw all of your attention, please, to our national conference taking place on the 26th and 27th of April at London Excel as part of the Health Plus Care Show. Knowing Jade Maloney as well as I do, I suspect within the next 10 seconds, there will probably be a link to registration in the chat here. If you are coming to that, it's going to be an absolute jamboree. Do please come along if you can. There you go. You see, I reckon that was 7.5, Jade. You're slipping. But it's going to be an absolute jamboree, all sorts of really interesting speakers. And you know, the lovely thing is, we're not going for the high and mighty, you know, the top of the hierarchy speakers. We're going through to our members who've got something interesting to say. And I think it will be all the more rich and empowering as a result of that, you know, real opinions that matter from people who are really doing the day job on a daily basis. So there we are. So yes, please, if you haven't yet registered for that, do come down. It will be super duper. And there's all sorts of opportunities to meet the entire Institute of Health and Social Care Management back office team, who will all be there. We're having a jamboree 2-day out. I mean, who knows what could possibly go wrong? All right, well, look, that's it for today, I think. Unless anybody else has anything gallantly important to say, let's leave it at that. David Quo, who's our chair, will be along at the next meeting of this. I should say, actually, one thing at the conference, we are doing an Oxford Union style debate around whether digital technology should be a thing for everybody. Speaking for it is going to be Darren from Cyberscale and somebody else, and speaking against is David Quo and myself. Can't wait for that. That's going to be about well, you're just going to have to be there if you really want to get into that. All right, that's it. It is worth mentioning that it is a paid for event, but if you're a member of the Institute or you're a part of this special interest group, you get in for free. And Jade has just put in the code that you use, IHSCM 100, at the checkout. You save yourself, I think, several £100. I think I'm right in saying. All right, that's it for today. Thanks a million, everybody. Enjoy your weekend. Don't get stuck in the snow. Stay safe, stay strong, and thank you all for the brilliant work you're doing. Bye-bye.